Hello, I'm Paul van der Heyning. I'm Professor and Chairman of the Department of Otolaryngology and Head and Neck Surgery from the Antwerp University Hospital in Belgium. Cochlear implantation is a field of interest and of research, and recently we investigated the relationship between patients with very severe hearing loss getting a cochlear implantation and their cognitive function. Why are we so interested in it? Well, it started with a publication in 2013 of Professor Frank Lin from Baltimore. We knew that from a certain age on, our cognitive functioning declines. And he demonstrated that people with a hearing loss have an accelerated cognitive decline. And so, what is the question? The question is, our patients with cochlear implantation have very severe hearing loss. Can we demonstrate in this category of patients also their decline or their poor cognitive functioning in comparison with their age peers? And more importantly, can we influence this cognitive decline or this accelerated cognitive decline by doing a cochlear implantation? So the question is, which of the models are applicable? In the left model, you see the cognitive decline, and then at a certain point where the marker is, we do a cochlear implantation, but unfortunately cochlear implantation has no influence and the accelerated decline progresses. Or we do the cochlear implantation and there is no catch-up, but from the moment that the patient got their cochlear implant, there is no further accelerated decline. And hopefully, the third model, they do a catch-up. What went wrong before by their hearing loss is recuperated by the cochlear implant, and their cognitive functioning is similar to those of their normal for age hearing peers. Of course, we speak about the category of patients that are older than 55 years. There have been already 3 studies that analyzed this cognitive function. And the 3 studies from Mosnier, Cossetti and Castiglione, they showed in their test that there is an improvement of cognitive capabilities in these older adults once they got the cochlear implant, and this within 1 year. We wanted to correlate that with their auditory capabilities. We wanted to use this also and redo this with a test which is specifically developed for hard of hearing people. Indeed, most of the tests that assess cognitive functioning need also some auditory capabilities because they are presented orally. So our first step was to define a test which was apt for people with a severe hearing loss, and our attention went to the repeatable battery for the assessment of neuropsychological status. It calls RBANS, and we adapted that test for hearing impaired subjects. What is this particular on this test, on this RBANS test? RBANS test assesses your cognitive functioning in 5 domains. It is immediate memory, visual, spatial and constructual capabilities, language, attention and delayed memory. And there is an overall score for these 5 domains, and which is particular for this patient. It assesses not only mild cognitive impairment or dementia, no, it assesses also normative cognitive functioning, and the outcome measure compares this with a normative database. It's like an IQ test. That means when the outcome is 100, It means that your cognitive functioning is just average for your gender and age category. Of course, older people will function less than younger people, but if they functioning, both categories, the younger and the older, functioning equally well as their age peers, then both groups will score 100. We adapted the test so that it is presented also in a visual way and that it became independent of the auditory capabilities of the particular person that we were testing. In a first approach, we did this RBANS test in a series of patients aged between 55 and 90, and we did also a minimal auditory outcome examination with speech in quiet, speech in noise, auditory capabilities. What are the results of this cross-sectional test? This is the category of our patients. The youngest was 58, the oldest 94. And all patients had the bilateral severe hearing loss. That means a hearing loss of at least 85 decibels. They got a cochlear implant and they had varying experiences with cochlear implantation. All had a stable map. That means they had their cochlear implant between 1 year and 19 years. The results. So remember, 100 means average for their age. Well, it is clear that our category of patients with a cochlear implant performed significantly poorer than their age peers, because our average in our category, in our population, should be 100 and not 85. They score more than one standard deviation lower. If we look to the subdomains, then we see that in the subdomains it is especially immediate memory, attention and delayed memory that were the reason why the average score was lower than we expected for people with normal hearing and the same age. So indeed, we found a confirmation of the studies of limb. Patients with hearing loss score poorer than patients that have normal hearing. And especially in our category, and one of the corollaries we have to ask ourselves, do we need to do another approach in these patients? Do they need another kind of rehabilitation? When we do explanations and approach them, don't we have to adapt our rehabilitation programs? But this is a cross-sectional study, and we further explored this cross-sectional study. For instance, in this graph, you will see on the x-axis the number of years of experience, and in the y-axis, the RBANS score. It is clear on this graph that whether patients had 1 year experience or 90 years experience, so long time use of a cochlear implant, that there was no influence of the years of use of the cochlear implants on the RBANS score. So that means if during the years after cochlear implantation the accelerated decline would progress, then we would expect that by longer use of the cochlear implant, the RBANS score should be lower. This was not the case. It is not a proof. It's an indication that maybe cochlear implantation stops this accelerated decline. But we need other and newer elements of proof for this hypothesis. Another finding in this category was that there is a relationship between the RBANS score, here you see the RBANS score at the x-axis, and the speech understanding in noise. In the y-axis you see the speech reception threshold. It is the 50% speech understanding in varying conditions with background noise, and with more background noise, which is more difficult, then we go to 0 or -5. At 0, speech and noise are equivalent. And so lower scores are better. You see that relationship, that if the RBANS score is higher, the speech understanding in noise is better. And this was statistically significant also after correction for age. So this is another important finding, that this relationship in cognitive function has a repercussion on the speech understanding of these patients. And maybe, indeed again, we have to redirect our rehabilitation programs. Now we started in a prospective study. We started by assessing a number of patients before the cochlear implant, and then after 6 months, and after 1 year. And we see whether we could get further proof of these conclusions of the first studies. Cochlear, all the implants patients have a poor cognition, and maybe CI might stop this accelerated cognitive decline. So we start now with this longitudinal study, and you see here the design of the study. Preoperatively, we have at this moment a limited number of people, 20 people, with age between 55 and 85 years. Again, it are people with bilateral severe to profound hearing loss, more or equal than 85 decibels hearing loss, and that were implanted with a Medel implant. We look first at the auditory capabilities and the outcomes of this cochlear implantation. At the left panel, you see the speech recognition in quiet. And you see that there is a very significant improvement of the speech understanding in quiet, going from 15% to 80% at the 6 months point, in a quite strict test, monosyllabic test. So we confirm that all the patients have benefit from cochlear implantation and have an improved speech understanding. At the right panel, you see the speech in noise test, the adaptive speech in noise with speech reception threshold. So in this graph, lower on the y-axis is better speech understanding, and also you see a steep improvement, a very important improvement of speech in surrounding noise by these older patients. We did also quality of life studies, and we used the Nijmegen cochlear implant questionnaire before and after cochlear implantation. And you see that in the different subdomains, the total score, basic sound perception, advanced sound perception, speech production, self-esteem, activities, social interaction, that in all these patients we had an improvement, a significant improvement of all their social activities and self-esteem and quality of life measures. Now we look whether this evolution is paralleled by an improvement of their cognitive capabilities. Now we look at the RBANS test. At the left panel, you see each time in the y-axis the RBANS score, and then at the x-axis pre, at 6 months and at 12 months. And the total score indeed improves. So we found similar findings than the first 3 studies, and this test was now done with something which is independent of hearing better in this test. The subdomains in which they improved was immediate memory, was attention, and was also delayed memory. It's maybe hard to explain it at this moment, but it is in line with former studies. If we think that we have arguments then although we see a catch-up after 6 months, well, they do not get at the end completely to the level of their normal for age hearing peers. There's a small catch-up, and we think at this moment that there are quite good arguments that cochlear implantation at least stops the accelerated decline. This has far-reaching consequences. That means that older people that get a cochlear implant, due to the fact that they have not this accelerated decline, that it will take more time before they get to the line of mild cognitive impairment or even dementia. It will delay the period of dementia, and this has to be further investigated, but probably also will be able, due to that, to keep people longer at home, that they can stay longer at home and not go to a nursing home. And this has to be brought into this complete picture of costs of cochlear implantation in older adults. It has been a debate, and some came up with the cost item and said, well, why would you use such an expensive tool in people with maybe a limited life expectation? Well, I think we have here an answer. We have here another field of discussion, because improving cognition and stopping accelerated decline is unique. It is one of the only therapies at this moment where we could prove, or where there will be further evidence that we have an influence on this massive problem for our society, older society, and that's that of dementia. If we can prove this, then we can have something done that other fields are not able to do at this time. There are a number of criticisms on this study, but we will go on in multi-center studies, prospectively, also comparing people that do not get a cochlear implant, and compare them over time. And this is a short time study, a study at 6 months and 1 year. We see in these older patients that they hear better, that their auditory capabilities improve in 6 months, but that we have to wait until 12 months to have a statistical significant improvement of their auditory capabilities. But these prospective studies will give more firm proof of what we find now. Anyway, the findings in these studies are reason to go on with this analysis, and will bring the discussion of cochlear implantation in all the patients to another level. So, conclusion, there's a poor cognition in older patients. All the CI recipients benefit considerably from cochlear implantation, and the speed of decline of cognitive function is influenced by cochlear implantation and is probably normalized. And we saw this already after 12 months. I thank you for your attention.